think there's a number of things that contribute to the very long delay in diagnosis. I think one of them is that the sort of gold standard, definitive, traditional diagnosis is through a surgical procedure, through a laparoscopy. Another factor is just that there's such a wide range of potential conditions that could present with abdominal pain and pelvic pain in women. So there's a lot of overlap with GI and GU and other conditions that involve systems outside of the reproductive tract. I think on the side of the clinician, there may be insufficient education in some cases on the presenting signs and symptoms of endometriosis. There may be, a lack of comfort with endometriosis procedures that can be, difficult, complex procedures. And I think the combination of all of those factors can lead to this very long delay in diagnosis. I think what the recent ACOG bulletin highlights that just came out is to sort of prioritize clinical diagnosis of endometriosis when it gets patients to treatment more quickly than waiting for a laparoscopy for a definitive diagnosis. It's not that laparoscopy is no longer part of the diagnosis. This is still, critical and often necessary to make a definitive diagnosis, but it does not mean that patients need to wait for this in order to initiate treatment. I think counseling patients who have pelvic pain, it must be very much a sort of shared decision-making approach in which patients have an active role in this discussion. There are patients who may want to proceed directly to laparoscopy, regardless of physical exam findings. And that is something certainly that should be offered to them as an option. But there will also be patients who prefer to avoid a surgical procedure, but yet want at least empiric treatment to address their pain and symptoms. There's a lot of interest in biomarkers and non-invasive techniques of diagnosing endometriosis. I think, unfortunately, they're not yet ready for prime time. For the most part, the diagnostic accuracy of the biomarkers doesn't exceed, the combination of physical exam and imaging in the sensitivity of the diagnosis. So I don't know that there's a clear role for them just yet, but that may change as things go on. It would be certainly something that could dramatically shorten the time to diagnosis if there were something that were easier to do than a laparoscopy in order to reach a definitive diagnosis. Yeah, I think what's really important with regard to fertility is to, of course, counsel patients that fertility may be an issue when they are dealing with a diagnosis of endometriosis. And endometriosis is very common in patients with infertility. It's hard to determine an exact percentage, but some data suggests up to 50 to 60% of patients with infertility may be affected by endometriosis. I think for patients who have endometriosis and want fertility in the future or think that they might want it or are unsure, a consultation with a reproductive endocrinologist early on is a really good idea. Often these patients are candidates for fertility preservation. Sometimes I see patients who are, in their later 30s or early 40s who have had many years of endometriosis. They may have large endometriomas on the ovary. They may have had multiple procedures that have impacted the ovaries. And we know that anytime we are removing an endometrioma, there is an impact to the ovarian reserve. We know that endometriosis itself, and in particular, the presence of an endometrioma can impact the ovarian reserve. And coupled with the fact that these patients are more likely to need fertility treatment, especially in vitro fertilization. I think a really good idea for these patients early on, as young as possible, before surgery, if possible, to meet with a reproductive endocrinologist to discuss the possibility of fertility preservation and understand what options are available to them in terms of fertility.